Please go ahead.
I would like to share a story that starts in daily clinical workflow and ends in the large-scale research. This is not a story about an algorithm, it's a story about visibility. What began as a routine ECG management tool gradually became a scalable research engine, and more importantly, a mirror of how we actually make clinical decisions. And before we start, let me briefly introduce myself. Uh, Okay, yes, I'm Dr. Cihan. I work in a high-volume emergency department, and I have a strong clinical interest in perioperative risk assessment and ECG-based decision making. This means reviewing large numbers of ECGs every day in real-world clinical workflows. My focus has been ECG-based risk assessment and how digital ECG systems can turn large-scale data into critical, practical clinical decisions. This experience comes from our daily practice in Denizli from Turkey. Okay, in a tertiary care hospital, ECGs are everywhere. Perioperative evaluations, patients' clinics, inpatients, admissions, consultations. ECGs are part of the background noise of daily practice. We review maybe hundreds of ECGs every day, often maybe always under time pressure. In this environment, silent but critical parameters like QT interval are especially easy to overlook. The problem is not lack of information, as you know. The real problem is lack of access to actionable information, in my opinion. Okay, ECG interpretation is not a single parameter task, as you know. QT and QTC measurement is time-consuming uh, and maybe highly variable between clinicians. And SD segment changes can be subtle, and borderline QRS widening or PR prolongation may go unnoticed. And T-wave morphology requires focused attention. All of this is manageable when you look at a few ECGs per day, no problem. But not when you are dealing with thousands, it's maybe a problem. In real world workflow, many ECGs are labeled as normal because we have no time. But normal levels can still hide clinically significant risk. The end results is simple and uncomfortable. High-risk patients proceed to procedures without being recognizing. It's very high risk. This is where a system-level approach becomes essential. A centralized ECG platform provides a shared memory for the entire hospital. Key parameters are analyzed automatically, data becomes searchable and filterable. Most importantly, patterns emerge, patterns that are invisible when ECGs are reviewed one by one. We need to large-scale look. Okay, the core idea is straightforward. MUSE transforms ECG interpretation from a person-dependent task into a system-driven, data-powered process. Instead of relying on individual attention, we rely on structured visibility. Before diving into the data, it's worth pausing for a moment. This study didn't start with a dissatisfaction or failure. It started with awareness. As clinicians, we are trained to look for patterns and equally trained to question what we might be missing. Over time, we began to ask ourselves whether some ECG findings, although technically visible and were not fully integrated into our clinical thinking. Okay, this question gradually evolved into a structured clinical inquiry, which eventually became a published study. But the publication itself was not the main goal. The real goal was better to understand how ECG information is translated or sometimes not translated into clinical decisions. This is our published study from 2020. I will not read this abstract. I'm so sorry. But I can share the link if you want. Okay. In daily perioperative practice, we review ECGs continuously. As you know, QT prolongation is rarely the primary reason for consultation, very rarely. And that is understandable because it is often asymptomatic. However, we also know that anesthesia, electrolyte shifts, and QT prolongation medications can amplify arrhythmic risk. This raises an important clinical curiosity. Are we consistently integrating QT information into our decision making, or is it being treated as background data? At this point, the focus of our thinking became very precise. We were not asking how many patients had long QT, no problem. We see that, no problem. But we were asking whether long QT actually changed clinical behavior. This subtle shift from counting findings to examining responses defining the entire study. To answer that question reliably, we needed consistency. Individual ECG review depends heavily on attention, experience, and time, as you know. And in high volume settings, variability is inevitable. A system-level approach allowed us to look at ECG data in a standardized, reproducible way without adding cognitive burden to clinicians, as you know. And we brought all ECGs into a centralized structure. We have a database, as you know. QTC values were calculated automatically, and clinical meaningful thresholds were applied. And finally, we focused on the preoperative setting where QT-related risk has immediate implications. This workflow was designed not to replace clinical judgment, but to support it. What emerged was a transition from complexity to clarity. Instead of thousands of ECGs, clinicians were presented with focused relevant subset. This step was crucial. It transformed raw data into something clinically usable. It's very important. During the study period, I will share a very important data in these slides. We analyzed 96,000 ECGs recorded in our hospital. This is exactly the kind of volume where manual review is no longer realistic, as you know. Using the MUSE system, we applied automated QTC analysis across the entire dataset. From this large pool, 20,000 nearly patients were identified as having a prolonged QTC based on predefined thresholds. Therefore, we applied a second clinically meaningful filter, patients evaluated in the preoperative clinic. After this step, the population was narrowed down to 46 patients. And following manual verification, 45 cases were confirming as true long QT syndrome. So what you see here is the case strength of the system. Complex, large-scale ECG data transformed into a small, actionable clinical population. It's very important transformation, in my opinion. This represents a final preoperative long QTC syndrome prevalence, very low, and identified without increasing clinical workload. It's very important. Okay, I will share some tables with you. The patient population was older and had a significant burden of comorbidities. Importantly, electrolyte abnormalities were not prominent, and QT prolongation was therefore not an incidental laboratory phenomenon, but a genuine ECG finding. When we examined consultation patterns, an interesting observation emerged. Consultations were primarily driven by known cardiac disease or medication management. QT prolongation alone rarely prompted further evaluation. Most procedures were elective and non-cardiac, as you see. This emphasizes that QT-related risk can exist even in settings perceived as low risk, reinforcing the value of systematic screening. And QT prolongation often coexists with conduction abnormalities. Despite this, clinical responses remained limited, highlighting a gap between data availability and clinical action. This led us to a central realization because the issue was not whether QT prolongation could be detected. No problem. It clearly could be. The system solve the QT prolongation, no problem. The issue was whether detection translated into action. There is a problem. Our findings show that visibility alone is not enough. Clinical impact requires interpretation and integration into workflow. And detection without interpretation doesn't improve patient safety. The hospitals for patients, as you know. And mm, large ECG datasets became valuable only when they are rapidly screenable. System-level platforms like MUSE allow clinicians to identify rare but meaningful patterns and act on them without increasing workload. This is where digital systems truly support clinical care. And MUSE simplified daily workflow and enabled large-scale ECG screening. More importantly, it helped us to see where attention can be sharpened. And real value of ECG systems lies not in storing data, uh, but in helping clinicians notice what truly matters. Clarity emerges when complexity becomes surgical, in my opinion. This has led us to a central realization, and the issue was not whether QT prolongation could be detected. It clearly could. The issue was whether detection translated into action, in my opinion. Okay.
Thank you very much, Dr. Cihan. Are you still with us, or did we lose you?
Okay.
I think we have a little bit poor network
Yes,
connection right
yes,
now.
I'm here. What is the
Yes, good.
easiest way to
Perfect.
export data from MUSE in
Yes.
XML for large files?
Yeah, so maybe for the first question, I'm not sure if
Okay.
you are ready to answer that
Do you
one,
hear
but or if you would like us to answer that rather.
me? Okay, I can answer. What is
Yeah.
the easiest way to export data? I don't know. I don't do
No,
this way.
no. So I can support in this one. So I
I'm
would
so
say,
sorry
yeah,
because
yeah, no worries.
I
So the
okay.
easiest way to export
I
data is
have a
probably,
uh,
so I would say the easiest way to export data is probably to contact your local sales team. So they are happy to support you with alternatives that we have. But one option is to do a database search within MUSE, and
okay.
then we can actually export the
I
data
don't know
from
the
there.
real way, but we are asking to our support team, could you search the data and could you filter the data? And we need these dates from January 2020 to January 2021, for example. And they are filtering data and gives us a very good uh, Excel spreadsheet. It's enough for
So,
us, and we start to study.
Dr. Gian, we have a little bit problem with your connectivity, so you are freezing from time to time.
Do you hear me?
Yes, now I hear you better. I think we are more aligned now. We had a little bit of delays in those answers. Can you hear
Okay.
me correctly now?
Yes, I hear you.
Perfect. Uh, So the first question I answered. The second question was from your clinical experience, what were the main challenges in QT measurement before using MUSE, and how did MUSE address these?
Okay, I can answer this question. Uh, this study wasn't actually not my first study at working with ECG-based measurements. Whether we are talking about QT, PR interval, and QRS duration, and fundamental challenge always the same, we have a problem scale. If we solve too many ECGs, we
Mhm.
cannot finish the studies. Before MUSE, it was simply not feasible to manual enter and analyze large numbers of ECGs one by one as structured dataset. Even if you try to, uh, even if you tried uh, to distribute the workload among multiple physicians, another major problem immediately emerged: inter-observer variability. Measurements differed depending on who was reading the ECGs and how fatigued they were and how much time they could dedicate to each tracing. So the limitation was not lack of clinical interest or awareness, but absence of a system that could handle large volumes of measurable ECG parameters in a standardized way. Uh, Muse fundamentally changed for me what this. I can now screen thousands of ECGs within seconds and using uniform measurement rules, and data are searchable, filterable, and consistent. As a result, inter-observer variability is no longer something I need to worry about because the measurement process is system-driven and rather than person-dependent. In short, Muse transformed ECG analysis from a manual, fragmented, and variable process into a scalable, reproducible, and reliable workflow.
Thank you. I believe actually the next question probably was for the previous speakers, and unfortunately they needed to drop if they were using orders to Muse or just relying on ADT and resulting. So we would need to go back to that one. And I think the next question is corresponding with the first one, that you try to export all of the tests for quite a large amount of data, close to 2 million tests. When you have this large amount of data, you definitely need our support. So I would
Yes, exactly.
raise raise a question to our sales team that in that case would be able to reach out to the right person within GE to support you with these data requests. So definitely contact your local salesperson and we can guide you further on how to support you exporting these data. Are there any additional questions for Dr. Jian? Otherwise, I have one question as well that I'm curious of. We know we have been discussing that manual reading of QT versus automated has really improved the way you can do data. How much, or do you ever, when trusting the automated QT measurements, do you feel that you manually need to recalculate, or do you trust the automated
Hmm.
versions? And when do you trust it versus when would you like to take a second opinion with your own measurement tools?
Okay, thank you for this question. I will show slides for it. Okay, please look at this slide. Uh, mm, the First of all, we didn't calculate any data or any QTG
Okay.
measurement. We start to filter it and management and end of stage. We checked all of ECGs, but this number is very low, 40 and 5. Actually, we have 40 and 6 patients had long QTC on preoperative system, but we checked all of ECGs and one of ECG excluded because it is not long QTC ECG. And then all of them, 40 and 5 patients has long QTC. We checked ECGs, the last step.
So you feel that it's few ECGs that you'd need to manually overread after getting the automated calculation?
Yes, we trust it.
Yes, good. Thank you very much.